Today, we are very pleased to have Dr. Jeffrey Wilson present today. He is board certified in psychiatry, child and adolescent psychiatry, and addiction psychiatry. He's an associate professor of pediatrics, psychiatry, and behavioral sciences at Macon and Joan Brock Virginia Health Sciences at Old Dominion University. He has been with CHKD's mental health program since 2022, and he serves as a child inpatient medical director at the Children's Pavilion. Dr. Wilson learned motivational interviewing from Bill Miller and from his Columbia mentor, Dr. Ned Nunez. He has spent more than 25 years using motivational interviewing to help young people make meaningful changes. So please join me in welcoming Dr. Wilson for today's talk, starting the conversation, SBIRT in pediatric primary care. Dr. Wilson.
Well, thank you for that nice introduction. It's a pleasure to be here today. Thank you everyone for joining. Quick question to start. It could be a rhetorical question. You're also able to use the chat if you like, which I probably won't be able to look at till the end of our talk when we're talking about discussions, talking about questions and discussing them. But here's the question. How many of you routinely ask your adolescent patients about substance use? Another thought maybe we can come back to in the discussion, at what age do we start asking about substance use? I've been shocked over the past year or two to find some fourth graders getting caught with vapes at school. Some things that for us to think about and talk some more about. This is not about becoming an addiction specialist or doing addiction treatment. Today's talk is about having one better conversation that you can have in under 5 minutes with your patients. We're going to introduce some of the principles of motivational interviewing, which we have demonstrated in evidence-based practice that SBIRT is a great way to get that training. So we're going to talk about SBIRT, which is screening, brief intervention, and referral to treatment. Before we get there, let me take a step back and frame why this matters in pediatric primary care. Most of the patients we see aren't addicted that are using. Many of them are in this at-risk middle zone or harmful use zone. We may all, depending upon the age of the kid and the substance, have different levels of comfort. But many kids are in this at-risk middle zone, and some have a substance use disorder. Substance use typically begins in adolescence. And we can have the most impact if we're talking to kids about use, not just abuse or disorder or use disorders. So what do we know about whether this works? SBIRT's been shown to reduce alcohol use in this age group. Brief interventions reduce risky use. Drug outcomes are mixed but promising. For other substances, we consistently see increased awareness, increased motivation, more engagement in treatment, and sometimes SBIRT can even be used for the referral to treatment piece to help promote their likelihood of following through with the referral. But mostly today, we're going to talk about having that conversation about that brief intervention. So even when use doesn't stop, risk can decrease, and that matters. And if we're talking to kids, they'll have the benefit of our knowledge of these substances. But we have to be careful how we impart that to them. Now, let me address what you might be thinking. I don't have time. I don't want to open the Pandora's box. This is not a 20-minute intervention. This is a 3-minute conversation. And you're not responsible to do it all in one visit. your role is to start the conversation in a way that keeps the door open. So how do we identify who to have the conversation with? So the S2BI was created pretty much for SBIRT, and it actually stands for Screening to Brief Intervention. Let's see. Give you an example of this. This CRAFFT screening tool has actually got the CRAFFT, and it's got a shortened version of the S2BI on it. It really just asks about alcohol, marijuana, cannabis products, anything else, illegal drugs, over-the-counter prescription drugs, and inhalants. And this is the CRAFFT, which we're going to explain in a second. So those are all available. They're non-proprietary. They're easy to gather, and these are things that your patients at a certain age should fill out in the waiting room, and you'd have this information when they came in. Only takes about 30 seconds to review the results with them. And the real challenge is not so much screening, it's what do you do if the child says yes? So as I was showing you on the form, let's see, I'll make this bigger. The CRAFFT stands for car, relax, alone, forget, family or friends, and trouble. So after you have the use inventory, that's what the CRAFFT stands for. Just to kind of brief you on that. All right. So let's make this real. Sabrina is a 10th grade girl. She's a strong student, or has been. And her friend group has been vaping some, and her mom saw them vaping. She's vaping weekly, using alcohol occasionally according to the S2BI, and her CRAFFT score is 4. Her mom is in recovery, and she feels like she's disappointed her. Sabrina has a lot of guilty feelings. Mom brought her in and mentions this to you privately at a well check. This is the kind of patient, we could see this week. What do you say first? Let's think about that for a second. Most of us instinctively go for, you've got to stop. Or we give advice. And many of us doctors types explain the medical context, or for me, the psychiatric context as well. And what I would get usually in return is shutdown, defensiveness, a missed opportunity. They've heard all that before. So instead, let's try a simple structure. The brief negotiated interview. It's evidence-based, it's grounded in motivational interviewing principles, and it's not meant to be therapy. It's just to start the conversation. And typically it can be done in about 3 to 5 minutes. How to do that? Ask, reflect, explore, scale, plan. So once she says, well, let's start with the beginning. So let's explain what these things are. Can we talk about vaping for a minute? Asking permission helps respect adolescents' autonomy, many of whom are dragged kicking and screaming to see psychiatrists or pediatricians, it kind of reduces resistance. Asking for permission empowers them to say yes or no. And if they say no, it gives you the opportunity to have that conversation with them. Then you reflect. This is going to depend on what Sabrina says, and it's really important to use the words, especially for adolescents, use the words that they're using and reflect that back to them. And you're going to notice that these are statements, not questions. A lot of us, when we are going through medical school and residency, we learn to ask all the right questions. One of the things that we learn, if you ever were to get trained in motivational interviewing, is you try to ask more, you try to use reflective statements more than you use questions. So it's around a 2-to-1 ratio was the target when I got trained in it a while back. So some examples of some reflective statements include, it sounds like vaping helps with stress. It feels normal when you're with your friends. So here are some examples. Instead of you need to stop, it sounds like this is helping you cope. Instead of that's dangerous, part of you sees benefits and part of you sees downsides. One of the things of that last reflective statement is that it's a double-sided reflection. And double-sided reflections pull for ambivalence, which is really the grist for change in motivational interviewing. A lot of times we're not sure about the ambivalence because we want to give a clear message about a medical procedure or something like that. But ambivalence about change is part of the fuel for change. And tipping that balance can favor change. Using double-sided reflections helps get there. Step 3, explore. What do you like about it? What are some downsides you've noted? This is where change actually begins, when patients hear themselves say both sides. The ambivalence is the fuel for change in motivational interviewing. It's the way we tip the scales in favor of change. And also working with adolescents, it also helps the adolescent own both sides of that, their own ambivalence about whether or not they should change, rather than just projecting all of those thoughts and feelings onto their parents, onto you, onto their teachers, onto the man or the authority. It helps them understand where their motivation lies, drawing out the ambivalence. So one of the things that we like to use in motivational interviewing and SBIRT is a readiness scale. And our readiness scales is how much do they think that they could change? How ready are you to make a change? Let's say Sabrina says 4. Sometimes it's helpful to ask, why not a 3 or a 5? And try to explore some of that motivation a little bit further. So step 5 is the plan. So this is the brief negotiated interview. What's one small change that you could make? Some examples could be reducing the frequency, avoiding certain times. This is best if the change talk comes from the child. If the change talk comes from the patient that we're talking to. And change talk has been shown to predict recovery. The more that we talk about change, the more that we can change, and the more that we do change. Sometimes these changes are unusual, like not smoking cannabis during the week. And sometimes figuring that out with the child is kind of complicated because you don't want the parents to think that you've given them permission to smoke cannabis on the weekend. So you have to be clear about some of those boundaries. Talk about that. Think about that. So the brief negotiated interview in action for Sabrina: ask, reflect, explore, scale, and plan. And this is a 3-minute conversation that can shift the trajectory and tip the scales in favor of change. Once a person experiences some of those small changes in their life, they can benefit from some of the recovery that's there and consider whether there are other ways to manage this. And for people that are early in that harmful use category, it can actually be preventative and helping them explore their autonomy in a helpful manner. So how would you do it with Sabrina? Um, Let me pull this all together. Sabrina, would it be okay if we talked about vaping for a minute? And listen. It sounds like it's been helping you manage stress lately. And you listen. Here's a question. What do you like about it? It's an open-ended question. So we're trying to get at that double-sided ambivalence or that double-sided reflection. And then what are some downsides you've noted? On a scale of 1 to 10, how ready are you to make any changes? Um, why not a lower or a higher number? What's one small change you might consider making today? Sometimes people aren't ready to change right then, so it becomes next week. If you have the opportunity to see them again, you could say, we can talk about this next time you come in. And there are sometimes when kids want to change, when they want more treatment or they realize how difficult it is, and that would change the focus more towards referral to treatment. So if you do nothing else, ask one question, reflect once, ask readiness, suggest one small step. It's a very abbreviated version, but it also can give you that what it feels like to reflect on the patient's statements and see how it opens up a conversation that you wouldn't have been able to have. See how you can start the conversation around some difficult topics. Many people over the years have used motivational interviewing for other things besides substance use. Even though Miller and Rolnick initially started this treatment for people with substance use disorders, it's also been applied to people with a wide variety of problems. It's been applied to people with diabetes. It's been applied to people that are struggling with overweight, any kind of health behavior. And there are a number of studies that demonstrate that. So the purpose of this talk today was to give you a sense of what are some of the skills that you need to start the conversation with substance use disorders. It does take a little bit longer than a lunch and learn to learn all of these things. So these resources can get you some more information about, one, a full adolescent SBIRT simulation, and two, free SBIRT trainings that are available. So if you scan these codes, we can learn more about this. And I thought it would save some time for just general discussion about substance use disorders in your practice, where this might be helpful, where it's not, and maybe work out some of the details of all this. So I'd like to take some questions. If anybody's interested. Okay, is that the end? Okay, I see a question in the chat. Would you like to unmute yourself and ask it, or would you like to put the question in the chat?
She put it in the chat. I don't think she can unmute, so I will read it to you.
Okay.
Oh, she just said she had a question. Melanie, if you could please type out your question for us.
Yeah, I have a question. Can you hear me?
Yes.
Okay, so how do you address a parent or the parents of younger patients that are vaping, even the 10th grader that you were discussing? If those patients don't have jobs or access to financial means, how do you address the parent as to where they are able to purchase those items for themselves if they don't have a job? Does that make sense?
So the younger the child, the more likely I'm going to want the parent to be involved. And some of that's going to be kind of using, I guess, some motivational questioning to help the child realize that they have to talk to the parent about it. But I would want to know if my 9-year-old were vaping. Even if I were vaping myself, I still would want to know. So I think it's important to think about that. The confidentiality aspect's a little bit complicated with older kids. So sometimes when you're asking permission to go through SBIRT, you might want to talk about the limits of your privacy or confidentiality. But when you start to get into the elementary school kids, I do think that there's a serious risk of harm. I think it's not good for any of the kids, like you said, even the 15-year-old. But it is concerning to me that 9-year-olds who aren't even in adolescence yet are sometimes vaping and exposing their developing brain to highly addictive substances. So I do think that that is an area where we do have to talk with the parents, the younger the child that they are. I think when you get into high school where substance use becomes more normative, I think it's important to think about. Now, this isn't generally considered substance abuse treatment, so I don't think you have to worry about the CFR around keeping substance abuse treatment confidential. But it is important. It is important to talk with the kids about where those limits lie. I think probably the youngest kid I've seen using heroin was in New Jersey, was 11. And I did have to talk with him about that. This was something that I had to talk to their parents about. And we did get them in a treatment program. I think heroin changes the level. It depends on the risk. But anyway, does that answer your question, Jill?
Some of the question. I think more of what my question was related to is if this child or adolescent doesn't have a job and they are able to purchase vape or even illegal substances. I think my question is more about how do you address the parent as to where they have access to the money to purchase those things if they aren't financially able to do that on their own. I mean, it's the parent giving them money. Is it allowance? Where do they get the money to purchase illegal substances if they're underage? And is that addressed with the parent?
They shouldn't be able to purchase them over the counter, or they shouldn't be able to purchase them anyway because they're too young.
Correct.
So a lot of times they're getting this at school from their friends. Sometimes they're stealing it from their parents or family members or older brothers or sisters. But you're right to think about access to that. And once a family knows about that, it is really helpful to talk about that access. And it's the same with suicide prevention and prevention of homicide. We want to safety plan them home. And it's the same with substances. The more you're exposed to, the more likely you're going to get dependent on it. And the younger you're exposed to it, the more difficult it is. This is a big thing now because we've had a fair number of kids overdose on their parents' cannabis gummies, and sometimes they're out of it for some time, and they're in the main hospital. And so access is a major consideration.
Okay, Dr. Wilson, we have a couple additional questions. If we have a patient with both depression and substance abuse, would SSRIs be helpful?
That is a great question. And once when I was initially trained, I think this was going back some 30 years and learning about substance abuse, most people would treat them one at a time. But the evidence is different. The evidence suggests that you should treat comorbid depression, and it is a risk factor. That said, does substance abuse contribute to depression? Yes. And does the opposite happen too? Does depression, it goes both ways. But most people would probably agree to try to treat both. But there's no reason not to prescribe an SSRI if somebody meets criteria for a major depression or even anxiety. Generalized anxiety disorder is also highly associated with substance use disorders, more in adults, but in kids, depression is a major risk factor for substance abuse. It may not fix the substance abuse. And if you're going through the SBIRT and they're not making the changes that they need to make, then that's where a referral to treatment is indicated. And hopefully at that point, you've built up enough motivation for them to recognize, yeah, I tried to stop this, but it's still a problem.
Great. So an additional question. Let me just get back to it. So what about if a parent is not accepting that the substance/vaping is an actual problem? They adamantly believe it is something entirely different. How do you address that?
That is challenging. I don't think I've ran into that problem. Sometimes I have ran into the problem with parents not believing the kid's actually using it, that the whole thing's made up, and denial's serious. But if I ran into this problem that they thought that So it's a little hard for this question because substance and vaping, they're all different, and all the different types of substances kind of matter. But when a parent's not accepting the actual problem, that's a role for us to have a conversation and talk with them. It's a little easier if the kid sees it as a problem and the parent doesn't, than if they both don't see it as a problem, because then you're going to lose a valuable ally in trying to talk about that with the parent. But the other piece of this is psychoeducation. I think there are a lot of good resources out there about youth vaping. One of them is Paul Harrell here at ODU. He's got some resources for kids that want to stop vaping or using cannabis on his website, and connects to some others different sites. So psychoeducation could also be helpful.
Yeah, I know in my experience in gastroenterology, I had that with some of the patients that had an eating disorder, that one or both of the parents were not believing that it may be anorexia nervosa, and insisting that there was an organic problem, IBD or something else. And then we had to sometimes maybe do some additional testing that certainly was extra costs and time, maybe to not necessarily just appease the parent, but be sure that it wasn't anything else. But it certainly is a problem when one or both of the parents are not on board with what you're proposing. Dr. Wilson, I don't know if you want to re-ask your additional question that you asked at the beginning. I think some people were maybe not prepared as to respond whether or not they do any screening.
That's a great suggestion. But first, let me just get back to Heather here. She said that the example was a child with cannabinoid hyperemesis, and the parent is aware that the teenager is using marijuana daily, but they feel strongly that the marijuana is not causing the emesis. It's something that's undiagnosed. That is a frustrating problem. And it's a fascinating problem because, usually cannabis reduces your chance of emesis, and there are, I think, particularly among people using the higher potency strains and using multiple different formulations, that is, like gummies, smoking, extracts, etc. Sometimes the receptors get overwhelmed and you end up with this phenomenon of the cannabinoid hyperemesis. It's kind of like, what do you do if a parent doesn't believe in autism, or doesn't believe in mental health or depression or inflammatory bowel disease, like Marco said? This is challenging, and I think sometimes more evidence can be helpful, like Dr. Sue mentioned. Sometimes more psychoeducation around it. And this is something that we are learning more and more about, is, we do see this often even here. So thank you for that question. That was a good one. So my question earlier was, how often do you ask about substance use in your practice? We got another question in the meantime. So that question can percolate, how often, and whether or not this is something you could implement, and what are the obstacles to implementing SBIRT in your practice? Something to think about. So Mindy asked, what motivational interviewing techniques have you found most effective with resistant or ambivalent teens? Along with this thought, how important do you think the first healthcare conversation about substance use is in shaping the future help-seeking behavior? Okay, that's a great question. So let me start with the beginning. So the most important thing is rapport, right? So we use reflective statements to build rapport with the patient, and it helps build rapport with patients because it helps them feel listened to. So reflective statements are very powerful, especially with upset parents or upset kids for whatever reason, because it helps people understand, yeah, he's got me or she's got me. So that's the one thing. How you talk about substance use from the first conversation, I think that could be helpful, but sometimes people aren't ready to talk about things. So I think just being open and inclusive, non-judgmental, respecting a person's autonomy, whatever their age, at a developmentally appropriate level. Those are all things that create the ground by which we can develop a fruitful change conversation. Did you have any more questions about that? Did that answer your question, Mindy? Well, thank you for all these great questions. Should we talk a little bit? Thanks for the response. Should we talk a little bit about what real world obstacles there are to having these conversations? Because it does get a little messy. Like I mentioned the confidentiality. I mentioned how busy you are with time. How do you follow up on this? What kinds of obstacles could we try to problem solve if you would like to talk about or ask questions about that? Okay. I don't see any questions.
Maybe out there.
Uh-oh.
There you go. There's difficulty is in not correcting.
I gotcha. I'm not sure if I understand that. The difficulty is in not.
Is in not correcting maybe the behavior. Yeah.
Okay. Yeah, like going on while somebody's continuing to use, that is struggling. And I think after a few times of that, you've built that rapport. This can morph into referral to treatment. It's way easier to listen to somebody to tell you to talk to somebody else when you've built that rapport and you know that person understands you. One of the things that also is very helpful with some of the clinics is if we can join their session in their place that they're at, like that they don't have to go to a brand new office or a scary substance abuse facility, or if there's a way to bring in that counseling. And I know that that's not always possible, but when I've been able to do that, I think that's very useful. Okay, something. So yeah, so this took me a lot of practice. When I was a addiction fellow in New York, yeah, I had to work really hard to stop asking questions to get to that 2-to-1 ratio because I think it can feel like SBIRT, and especially but motivational interviewing too, can feel like, oh, you're just letting people do whatever they want. But the goal of motivational interviewing is change, right? Most people don't come back and say, yeah, I stopped smoking cannabis during the week from the example before, and I'm just smoking on the weekend exactly the way I was hoping. Usually, if they talked about it with you before, there's something that's not working. And over time, you build that motivation for change, that motivation to actually get some treatment, actually get some help. But those are good questions and good thoughts.
Anything else from the audience? Please put any other comments or thoughts in the chat box. The QR code for the CME credit and the activity code is 31507. Then you also have the link for the evaluation form.
Well, thank you all for attending, and thank you for the invitation. If there are other substance abuse topics that you'd like to hear about, we could talk about that.
Wonderful. Thank you so much, Dr. Wilson. That was an excellent and very practical talk. Thank you, everyone, for your attendance today. We want to mention that next month, Lunch and Learn is on June 17th, and again, from noon to 1. Dr. Eric Engstrom from our Infectious Disease Division will be speaking on vaccination, the balance of risks and benefits to optimize outcomes.